Good day, everyone. The Society for Cardiovascular Magnetic Resonance is pleased to present this webinar, How to Start a Stress CMR Service. My name is Ryan Smith, and I will be your host for today's webinar. Please note that today's call is being recorded and all participant lines will be muted during the broadcast. Today's presentation will last for up to 60 minutes and include a specific question and answer period. However, you can enter a question for us at any time during today's presentation. You may submit a question by typing it into the Q&A box in the lower center of the window. Then be sure to click on the send button located next to the box. And now it is my pleasure to introduce Scott Yang, who will introduce today's speakers. Please go ahead, Scott. Oh, Scott, you're muted. Sorry.
My apologies. I was just saying it's a great honor to be invited to this event. I'm a clinical cardiologist and I work for Kaiser Permanente in Northern California, Kaiser. We have a very active cardiac MRI program, but I have to admit that stress perfusion MRI is a service that we haven't yet started to provide, but I'm very interested to get that started as soon as possible. So to be part of this panel is very exciting, and thank you for the opportunity. Our first speaker is Chiara Bucciarelli-Ducci, who I think all of us know very well. But briefly, she is a cardiologist working in London. As you all know, she's also the CEO for the Society of Cardiovascular Magnetic Resonance since 2019. She's also been on various committees for writing guidelines related to STEMI and other guidelines for ESC as well as position statements by CMR. And most importantly, she started a stress perfusion service from scratch in her work in London, and we'd love to hear how she did that.
Thank you, Scott, and good morning and good afternoon to all and good evening for those that's later at night that's joining us today. So I'm delighted to be here, and so I'm here in my capacity, I guess, of a practicing cardiologist doing lots of CMR, but also as the CEO of SCMR, as Scott said. So I think we were very pleased to see last week the newly released ACC and AHA guidelines for chest pain. And we were extremely pleased to see a lot of the literature that's been accumulating over the years being finally recognized in the chest pain guidelines, and with important indication for stress CMR, particularly class 1 indications in patients with acute chest pain and not known coronary artery disease, but also acute chest pain with prior CABG. And I'll show you cases during this talk on how we apply this in clinical practice on a service that you can start almost from scratch. The stable chest pain guidelines also indicate the stress CMR is indicated in class 1 in stable chest pain with not known coronary artery disease, and in stable chest pain with obstructive coronary artery disease. So again, more clinical cases from myself and also Chris on how we interpret these images, but also most importantly, how we acquire them. So I just wanted to share my experience. I am now based in London, but previously I was based in Bristol, and this is the map of the UK, for those of you that are less familiar. So it's not a huge country, yet there is a lot of CMR, and we'll try to understand why that's the case, and hopefully will be of inspiration for lots of us connected here to do more stress CMR. Bristol is a city that's an hour and a half west of London, and it's a city with 600 inhabitants, so it's large, it's not huge. And when I first arrived there in 2010, there was a small service with 300 scans done per annum, and the service grew to basically, let me show you here, grew to 3,000 MRI scans in the space of 9 years. And that growth was, steady and but progressive. So it was not kind of an immediate upward curve, but it was, progressive increase. And the increase was, so 15 times increased, 1,400% increase on stress on MRI in general. So that was cardiomyopathy, heart failure, and stress. And if we look just at the stress referrals, those are the stress referrals, they grew from 0, because we were doing none, to basically 200 in the first year, and then double and double and triple and double and triple, and up to doing 1,600. And in fact, the curves keeps going up. Okay, that meant that we were catering not just for Bristol. Bristol is a tertiary hospital, Our catchment area for primary PCI used to be 2.5 million. So I'm sure lots of centers can recognize themselves in that sort of volume of clinical work. But equally, we were able to progressively recruit patients from neighboring cities up to an hour away. They were started to refer stress perfusion CMRs to us. Initially outpatient, and then it became also inpatients. And there were many occurrences in which a local SPECT service was essentially replaced by our stress CMR service also for inpatients. And referring physician, after they became comfortable with the MRI stress perfusion reports and the accuracy that the report would provide, they had a preference to put the patient in the ambulance and sending the patient to us to do a stress perfusion CMR as opposed to do a local SPECT. And I don't say this with any disrespect. Sometimes I was the one incentivizing to do a local SPECT because it just was more practical for patients. But the physicians insisted that they really wanted to have accurate information. It was important for the management. And so, as a result, I was delighted to provide that service. But just to say, how much the service has increased, and that has been basically the result also of a lot of education that I've been doing in the region, and I've been visiting centers to explain what CMR in general, but also stress CMR can provide, literature in hand, and show them clinical cases. And so, although there was initial kind of curiosity / skepticism, on what the technique could offer, I think that was soon replaced by a lot of confidence in the report, because that's what they saw when they did angiograms, and also if the test was true, was negative, it was really high negative predictive value. So patient had no events, no other recurrence of symptoms and stuff. So I just thought I would show this what has been was a success story in this region of the world in Bristol, but there is no reason whatsoever that cannot be the case in your own center. And surely those of us connected here, Manish for Manchester in the UK, and also Mark Westwood for Barts in London, they basically have a similar experience of what I had. They start the service from scratch and then it grew exponentially. And now stress is one of the main indications, in fact, of their own service. And so in the UK, it is a success story, CMR, including stress perfusion. And just to bear in mind that in Bristol, I had an MRI scanner, which was in cardiology, which is also another model that can be reproduced easily, I guess, in your own hospitals, provided you have the volume to justify this. But the volume, grows with the referrals growing, and you have to do education to nurture that referral pattern. And our service was running from 8 a.m. until 8 p.m., so 12 hours a day. So 12 to 14 cases if we were keeping the protocol shorter. And also we were running alternative weekends. And when you reach this sort of volume, that's where a second scanner is so needed, right? And which is the case in many of those centers in the UK, and certainly was the case also for Bristol, but then I left to join the Brompton. So basically, to conclude, the success story here at Bristol has been a 10-fold increase in 10 years, and that hasn't happened overnight, but it just happens steady and not so slowly, but steady. So in other words, it's not going to be disruptive, I guess, for you or for your managers, to basically follow the success of your service. It's a healthy growth. And in fact, the good news is that particularly when it reaches a certain volume, it actually is making quite a bit of money. And my hospital was certainly very pleased with the service. And so it is a good business, I guess. And I mean, you just have to see all the centers that do CMR in London, well, in the UK, in fact. And the British Society of Cardiac MRI has done a survey that shows that there are over 80 centers in the UK doing stress CMR. And so if we average that out per population, I think, I would love, with my hat as the CMR CEO, to see, exponential growth of those services in the US as well, because there is no reason whatsoever why it wouldn't be the case. And in fact, I'm going to provoke you a little bit with this data here, that there is more CMR done in London, in the UK, roughly 40,000 CMRs. That's not stress, like old CMRs, than in the whole US. And if we consider CMS, CMS data, so CMS only report is like 26,000, in 2017. So this is slightly outdated. So I think there's been a growth, a bit of growth of stress perfusion and CMR in the US a little bit, but hasn't kind of skyrocketed. And so I think that skyrocket is what we need to see, because that's what we have in the UK, and there is no reason why it couldn't be the case in the US. In fact, people who claim, oh, there is not enough scanners, that's not true, because if you look at this data here, the number of MRI units in countries per million of patients, the US is the second country with most MRI machines after Japan. And I think the UK, features a lot lower. In fact, no, it's not even in the graph. And but nevertheless, so the bottom line is that the MRI machine is there for you to use. And if it's a machine that's not more older than 10 years, it can do cardiac, and it's already embedded in your software and your packaging. So it basically is just about using it. And if you don't know how to use it, we'll explain you now how to use it. And then the CMR will continue to provide you education and really walk you, step by step in succeeding. Yeah, otherwise, there is no reason why it could not be done. So first step, then as a clinician, you are already running your CMR service, or planning to start one. You want to add stress perfusion, like Scott's scenario. So what you have to do is you need to start identifying patients with indication for stress CMR. And now you have the ACC AHA chest pain guidelines. So you have all the indication, the stable chest pain, etc., known, without, known or not known coronary artery disease. You check the contraindication for a vasodilator drug, like asthma, for example, is the main one, or contraindication for an MRI altogether, like cerebral clips, because pretty much all the other contraindication now are not absolute contraindication, but relative contraindication. You send an appointment letter, plus the perfusion letter, in which it says the patient to withdraw from coffee and tea and chocolate 24 hours prior to the test. And this is because those caffeinated drinks can basically inactivate the action of adenosine or regadenoson for that matter. So simply, that's a simple prep. Patients should continue all the other drugs for that matter, in fact, and then you book the patient, and it's very, very easy, and it's very simple. It's any other appointment really. And by the way, the stressors are exactly the same that you use in nuclear medicine. So you shouldn't reinvent the wheel, but just basically follow that practice already that you do in your hospital. Patients arrive on the day, and normally you place 2 cannulas in the right and left arm. I just put as an indication the cannulas we use here, so a slightly larger one and a slightly smaller one, and the larger one for the contrast, because the contrast is more viscous than it would be the vasodilator stress, whether it's adenosine, regadenoson, or dipridamol, doesn't really matter. I think in the US, what you have available mainly is adenosine and regadenoson. In certain Mediterranean country is dipridamol. In Asia would be ATP. It doesn't matter. I think we're looking, it's a vasodilator stress. So the action is similar. The half-life perhaps slightly different. Mechanism of action can be slightly different, but we're talking minutes, and so not major difference. You run the drug for 3-4 minutes, and then you inject the contrast agents to take the pictures with. In the same arm that you put contrast, you also put the blood pressure monitoring, and so you measure the blood pressure before, during, and after the medications. There are some centers, like Mark in London, they don't measure blood pressure to every patient, but just those that are slightly more at risk to drop the blood pressure. This is because, in fact, those vasodilator drugs don't lower the blood pressure that much, to be honest. So it's more to give extra comfort to the patient and reassurance that it's been monitored. We can also put just 1 cannula. I think you can put like a 2-way tab if you cannot cannulate veins for kind of practical reasons, so you can cannulate a vein also in the hand, and that's where you can put the vasodilator drug to a smaller vein. And so you can be really creative on how you do it. With a single cannula, you put a 2-way tab. You then need to be certain that you run the adenosine first. When you inject the contrast, you need to be careful that you're not giving a bolus of adenosine, because then you will see that in the ECG, like a transient pause, which might be okay on a patient that's relatively healthy, but not so much in an elderly patient already with some kind of conduction disorders. So the way to do it then in the pump, and we can add some of those kind of practical steps, in fact, in the online education portal of CMR, but we can do like a mini flash, a very slow flash of saline, and then inject the proper saline to push the contrast. So there are various ways to do it, and certainly, as in the UK, we do huge volumes, like thousands of CMR. We have experience with all sorts of troubleshooting. You should do a 12-lead CCG simply to check that there isn't any second advanced heart blocks, because that would be a contraindication for stress perfusion, but that's the same for SPECT, I guess. And so, and then you proceed. I had once a patient that had atypical chest pain, women with a normal SPECT, and the one to no stress CMR could see small perfusion defects. And I did a 12-lead ECG, and she had 3rd-degree heart block with pulse. And it turns out she had cardiac sarcoidosis. So I put her in the scanner, and I kept, obviously with that rhythm, I kept the scan very quick. I done just a 10-minute scan, obviously no stress. And it turned out that that's what she was. So the MRI was still quite helpful. And then from MRI, she went to put the pacemaker. So it was quite a handy service, I guess, we provide. ECG gated, like for every CMR scan. And you put the patient prone typically, but if the patient is slightly claustrophobic, rather than abandoning the scan, what you can do is to put the patient prone. And basically the patient will be lying on the back, looking outside, which is open, and the scanner is around them. So that has worked in my experience on many occasions. You can put also relative at the end of the scanner. They can chitty chat with the patient, during the test, not during the pictures, but in between pictures, and that kind of helps and to achieve what we need to achieve. So we sit outside normally, and I think for the cardiologist starting stress perfusion, that's a source of anxiety to start, because when you do nuclear, when you do stress echo, you are next to the patient, and if the patient is like turning pale or look very sick, you see that straight away. It's slightly more complicated to do that through the control room, but there is a camera, as you see, and what's important that you still establish very clear verbal communication with the patient, and you explain beforehand what she or he is going to expect. To measure the blood pressure, you have options. You have this external, where it's MRI compatible blood pressure, which is obviously more expensive, but you can also do with non-MRI compatible equipment, and you can connect to the control room. Normally there is a hole, through the Faraday cage that you can pass through cables, or actually in my first days, I also did this below the door of the MRI unit. So you can be creative, I tell you, on what you can do with your equipment. So don't be put off if you don't have all this kind of fancy MRI equipment, MRI compatible equipment. The syringe, it's a normal syringe that you can get from CCU and elsewhere, and the syringe sits outside, and then you connect it through cables, and then you pass it through this passing through that you have on your wall, and with connecting cables, normally 4, and you use a full 50 mL syringe. Then you start your acquisition, you take your 4-chamber, and then you plan 3 short axes. I mean, currently the standard is that we do 3 slices only, and it's base, mid, and apical. And it's actually enough to cover the proximal, mid, and distal parts of the 3 coronary arteries. I mean, there are various technical developments in doing more, 6 slices, whole heart, but at the moment, the bread and butter is to do 3 slices, and it's good enough. I tell you, that's what I've been doing for 15 years to date. And the report has been accurate enough. So what you do, you start, so you have continuous ECG monitoring to the ECG that you have in the scanner. So it's not a diagnostic ECG, but you can monitor the heart rate for that matter. You measure the blood pressure roughly at the beginning, at the top of the stress, and at rest, more or less, I guess, with clinical flexibility as it allows. You start with your CNS images, long axis and short axis, and then you proceed and you do your perfusion. So you've given 4 minutes roughly of adenosine. The patient should respond, get some symptoms, get a heart rate increase, at least 10, 20% increase. And then you inject the contrast. And then basically, you acquire these images. And you see already perfusion effect here is very clear, right? You see the inferior wall, I see the inferior wall here. Then with the contrast given, I normally give 0.1 millimoles per kilo a minute of contrast, any contrast you want. That's normally the dose you give for visual assessment. And then with that contrast given, 10 minutes later, you do your late gut, and obviously here, just put 3 slices, but you do your long and short axis. And then you do your rest perfusion, normally, around 20 minutes, let's say 15 minutes after stress. And then you see that the inducible perfusion effect is no longer present. So it's inducible, and it is indeed reversible. Traditionally it's 1 hour scan, but actually we're becoming quicker, and that can be reduced to 30 minutes. That's what I've been doing in Bristol. That's what Leeds has been doing. And there is a JACC imaging paper that says that you can do it in 30 minutes and you're not compromising quality. You're just becoming quicker and efficient. And so this is possible, and I really encourage everybody to do so. So here I just wanted to show you a case. Let me check how I'm doing with time. A case of a 51 Caucasian male with hypertension and risk factors, so high cholesterol and hypertension. So she has chest discomfort and is a typical chest pain. So she's in the intermediate risk, of coronary artery disease. I guess traditionally, if it will make sense to do a stress perfusion test. What can you do? You can do all the perfusion tests, but let's say you do CMR because you're changing practice and you want to kind of modernize what you do. And basically we take the 3 slices, basal, mid, and apical. So here I actually did not plan it properly. I'm a little too high. You see there is a bit of LVOT, which is not ideal, but sometimes happens because patients tend to kind of overbreathe, during adenosine, they feel a bit short of breath. And so that's where the movement occurs. So better planning was required here. So nevertheless, let me guide you through here. Do stress and corresponding rest. I'm going to stop it here. You see there is this perfusion effect here and here and nowhere else. I mean, the rest kind of takes a bit longer to circulate, but you see there is no perfusion effect there. And so there is an inducible, in fact, the next one, inducible perfusion effect here and here. It's very clear visually, right? And so the way I reported it is a discrete inducible perfusion effect in the mid cavity in apical anterior wall, white arrow. I also went as far as saying this is likely a large D1 territory. And the reason why I said that, it's LAD territory, but it's not encompassing the all LAD territory. So it was likely a branch LAD. So I kind of called the vessel at my own risk, I guess, when you guess coronary anatomy. So the patient had an angiogram as a result, and she had indeed an osteo D1 stenosis. And in addition, I'm sure you've spotted that here there is large plaque. So the colleagues in the cath lab did FFR in that lesion, and the FFR was within normal range. And so that's a beautiful correspondence of what the images showed, and quite accurately, not difficult at all, provided you do the images properly, and easy reporting, visual assessment. Post-cabbage, Lima to LAD and 3 venous grafts on a lady that's 83 and angina and assessing ischemia. So here we go, what the images shows is circumferential perfusion defect, pretty much, circumferential, except the basal anterolateral wall. At the mid cavity is circumferential, and also at the apical level is septum and inferior wall, which is not present at rest. So this is 3 vessel perfusion ischemia. 3 vessel ischemia. And the reason I wanted to show you this is to say that there is no balance ischemia problems with CMR, because the high spatial resolution allows to see the subendocardial perfusion effects. And so we always have the epicardium as a reference, normal territory. And it's very unlikely, I guess, that somebody will have transmural ischemia in the 3 territories. If they do, probably they will go in pulmonary edema in the scanner. And so watch out for that, but it's very unlikely. And this is a beautiful, beautiful case demonstrating this. So I'm just gonna be quick because I don't want to step into Chris's time. We have 3 sequences you can use to do your perfusion imaging. You have a gradient echo EPI readout, gradient echo SSFP readout. In my experience, the easy bread and butter is really the gradient echo readout. That's where, it's a compromise between spatial temporal resolution and I think, that would be my recommendation to start, frankly. 3 slices, more than enough if you place it base, mid, and apex nicely. And the slice thickness is 8. And here are all the parameters that you can find in the guidelines here of SCMR. Same for the injection rate. There is sort of a standard injection rate you can use. It's all in the guidelines. So I really recommend you refer to this document, and that guides you step by step of what to do. So for acquisition, but also for post-processing, we've reported a couple together already, and is a visual assessment. You display the stress and rest, side by side. You also report them in the context of the late enhancement images. And then you basically need to window your settings a little better, optimize it. And then you need to also play frame by frame to see whether the perfusion defect occurs when really perfusion has occurred, or whether it occurs very early, which is when the contrast is arriving in the cavity. In that case, it will be an artifact. So those are the sort of kind of skills you have to develop in reporting it, but it really is few steps that you have to learn, and it's quite easy. If it's more, it gotta be more than 1 pixel, obviously, to be kind of true nature, ischemia, and also needs to be in keeping with the corneal distribution. Pitfalls and artifacts, like you have it in every modality, including with stress CMR. So dark band can mimic a true perfusion defect. So that's where the experience comes into play. So good image quality as well. But it's all doable with experience. Next webinar, next Monday, we'll discuss exactly how to read cases. So don't miss it. So we can do visual assessment. This is what I do in my practice, but also you can indulge in doing more complex calculation of myocardial blood flow and MPR. There now softwares actually do this very easily. When I did a PhD on this, I used to spend hours in doing this. Now it's like a few minutes. And this saving quantitative calculation really helps the accuracy of the report, but it's not essential. As I said, I base my practice purely on visual assessment. And again, the guidelines on how to report images as well. So to conclude, I think I showed you that CMR in coronary artery disease is really valuable, and more so than ever, given the technology and given the data that's accumulated in the literature. There is clinical value because it's safe, accurate, there is no radiation. It's one test in which you measure volumes, you look at lake odds and viability, and you do stress imaging. And you can also find some cardiomyopathic processes on top. Maybe chest pain had nothing to do with coronary artery disease altogether. Or find hiatus hernia and other causes of atypical chest pain, which can also occur. Economic, it's basically can be a cost effective. We'll discuss this in the discussion, and also a lot less extra tests. And so you make the final diagnosis of your patient quicker. Healthy revenue for the hospital and also for the physicians, particularly if the volume gets to a critical point. And also personalized medicine is really a key word nowadays, and CMR is the perfect tool. So value here for everybody, patients, doctors, and healthcare system and payers. Right, with that, I thank you so much for your attention.
Thank you, Kira. That was wonderful. We'll take questions after our second speaker. Let me introduce our second speaker, Dr. Christopher Dyke. He's a practicing cardiologist and an advanced imaging specialist at National Jewish Health in Denver, Colorado. He trained at Duke University, then did a 2-year CMR fellowship at the NIH before returning to Duke University as a professor of medicine. He then left Duke to Anchorage, Alaska, where he had a very active practice at Alaska Heart and Vascular Institute. After which he's now returned back to the mainland US. He's working at National Jewish Health and the Denver Metroplex in Denver, Colorado. Dr. Dyke is also the current chairperson of the Clinical Practice Committee of the Society of Cardiovascular Magnetic Resonance. Chris?
Great, thank you, Dr. Yang. And greetings from a beautiful sunny morning in Denver, Colorado. It's a pleasure to be here with you. I think this is an exciting time for CMR in the United States. You've heard basically what has happened across the pond that's been going for about 10 years. We have a lot to learn from that. And I think that this kind of class 1 indication by our American CV societies will be a catalyst for us to kind of use that as a bridge to go into a new referral pattern where we're able to utilize a more comprehensive, accurate, and value-based imaging modality. So my practice in kind of vasodilator stress CMR started about 20 years ago, pretty sobering, but I've been across a spectrum of different practice settings. I've been at the government, at the NIH, in an academic setting at Duke University, at a community-based private practice at the Alaska Heart and Vascular Institute, and now I'm in a kind of hybrid academic community-based practice at National Jewish Health and St. Joseph Hospital. So my hope is to bring some insights into that experience over time, but mostly to inspire you, to encourage you, that this is indeed possible in the United States. I'll just start with a little anecdote. I don't have a slide to show kind of volume changes over time, but when I left Duke for Anchorage, Alaska, which is a town of 300,000 people, there was no stress CMR available. And in about a 3 to 4 year process, we were doing 1,200 scans a year. And that compares to what we were seeing in the Denver Metroplex just 2 years ago. If you look kind of the two biggest providers here, it was about a similar volume. So there are disparities across the United States. I think part of it is just experience, part of it is engagement, part of it is learning lessons. But I think these new documents, as we start moving and demonstrating the evidence that's already been shown with CMR and getting it out to the community, getting it out to the payers, I think will really transform how we can provide care for our cardiovascular patients. So let me start with just a brief background in the United States, just to set the stage as to why we are behind Europe. You know, unfortunately, the stark reality is that economics really is our key driving factor. And, you know, dollars and cents matter. To be a successful program, you really need to show a return on investment. So you take a technology like a nuclear camera, which actually has fairly good reimbursement at a fairly low entry price for a capital investment. And you can see why a technology like that has thrived in the community. But as those of us who are experienced in CMR, we've seen this and we know that this exists and we're trying to address that. But the consequence of that in the community is our fellows that are training see that. And if they don't see the utilization of CMR, they don't get the training in CMR. So it all has kind of downstream consequences. So the hope is that with building up CMR in our guidelines, with having payers be more cognizant of this, with developing rapid protocols like you've heard about, we can change that underpenetrance that we're seeing in CMR and continue this kind of groundswell of growth that I think will only improve the care for our patients. So across the country, I've spoken with many colleagues, we are seeing kind of a softening of pre-authorization approvals for stress CMR specifically. Can't remember the last time I had to do a peer-to-peer for this, for example. And it is a technology that I think as compared to other imaging technologies, we are seeing some bumps in reimbursement. And I think that might even change more in the future as we utilize this more and understand the value that it provides. And when you take again this evidence that has been demonstrated with our cardiovascular societies in the Americas, hopefully our champions will then start gravitating towards this and start utilizing more. And then you combine on top of that technological advancements that we're seeing. So improved gradients, higher field strengths, looking at combining that with deep learning and artificial intelligence, you can imagine that our potential is limitless. And that potential is driven also by being able to have a more rapid protocol. So SCMR, their focus this year really is establishing how best we can get these patients through a scan. As you know, right now, it can be a fairly lengthy process. And I think that then will translate in the United States as an economic boom and might indeed be more of a revolution than an evolution. So I'm going to focus on kind of some practical and clinical considerations as we build this. Kira did a very nice job of kind of showing why this is important, showing how we can do this. This is more of those kind of aspects to consider as you're developing your program. And the first and the most important that I've seen is that as a key to success, you really want to see alignment across all of your key stakeholders. Now, clearly, clinical needs, clinical interest needs to exist. And at the heart of every program that's successful, you have a physician who is working tirelessly to build the program, develop the program, to look at protocols, to develop the infrastructure, to meet with referring providers. but it's really that alignment across the entire kind of hierarchy. You need to start obviously foundational with a practice or hospital to provide the resources for you to be successful. Because as Kiara highlighted, we have these technologies. It's just how we utilize those, but it does potentially displace other volumes. These are important conversations to have at a high level within your hospital or health system. Once those players are engaged, it makes it very easy for you to build a program, because once your referring providers see the images, see how it impacts their patient care, it can be transformative. And I think that is the critical aspect as you're building a program, is to really connect with your referring providers. You know, we have so much data, we have so much evidence now in CMR, and then you combine that with the images. You know, seeing is believing is a very powerful statement, but it's so true. And those kind of things resonate with referring providers. And not even just to set the stage, you know, once a patient's been through the examination, to be able to distribute those images to them with different software or whatnot, to be able to consolidate the rationale for referral and what you're seeing. I mean, for example, we can see things that you might not see on a nuclear scan. Maybe the person has an apical thrombus. In Alaska, in 13 years, I found 9 cases of primary lung cancer that would not have been seen with a nuclear scan. And so it does offer a lot to our referring providers. From a payer perspective, a little more complicated. When I moved to Alaska, no one had seen a stress CMR CPT. So I did make a point to meet with all the representatives for the major payers. And I think that did soften and smooth the kind of initial economic impact that our program had. Where I am now, care in Denver is a little more fragmented, a little more fractured, lots of payers, lots of different health systems. So more impractical in that perspective, but we are dealing with that on an ongoing basis. We're evaluating who's denying, we're evaluating successes in targeting those things individually. And those are important. Again, economics are key in the United States. So engaging those people, educating them to the cost-effective strategies can be very valuable as you're setting up a program for success. There are unique practice characteristics in different settings that should be considered. For example, in an academic center, you may already have the physician in the control room training fellows, training technologists. So that increase in ancillary personnel that you need, nursing and physicians or their proxy for the stress supervision, may already be there. And that might be a more, easy transition. In the community, may be a little more challenging. So in Alaska, we had our MRI program was in the outpatient clinic setting. And we had it on a floor that had all of our imaging. So we already had a pool of imaging nurses that could serve as the administrators for the stress protocol. So we didn't cross-train everybody. I'm a firm believer that I really wanted key individuals just to keep patients safe in a magnet environment. But thinking through those, finding the advanced practice provider, the NP we had to supervise those, educating them, really just made the program hum. And I would just read my studies at night. It was on autopilot and worked really well. Where I am now, a little bit different. I'm on a shared magnet in a hospital setting. So we're doing inpatients and outpatients. And because it's in radiology, the department didn't have nurses that felt comfortable with doing stress supervision. So again, that alignment's important because we were able to engage the hospital and have conversations to be able to utilize resources in cardiology to do the stress supervision, administration of the vasodilator for our radiology-based program. And that's worked very well, it was super smooth, but without that alignment, that would not have been possible. So there are different considerations, whether it's cardiology, radiology, or more of a collaborative experience as you make these kind of practical decisions when you set up a program. And unfortunately, financial models still drive this, and that may all relate to your patient population. So if you're seeing mostly Medicare patients, the good news is there's a fairly straightforward pre-approval process for that. The bad news is reimbursement's lower. So it's just setting the expectations with the higher level administrators as to that piece of the puzzle. From a health insurance perspective, obviously these are patients in the United States that people are more desirable because they offer additional reimbursement. So figuring out those patients, how to utilize those payers, working through high deductibles now, and do patients have to pay a higher copay, or are they paying all of it? Those are considerations that have to be made as you're building the program, as you look at the different patient populations you're going to see. Health plans like Kaiser sometimes have more of a cost containment model. And so we have a huge, so Colorado Permanente is a part of our practice pattern. And they're probably our biggest referral population. So I think, thinking about these things beforehand, where the patients are coming from, who's paying for these patients, how to build the program are all important considerations to set the stage for success. And when you do those things, really, it's easy to talk about CMR with all the data that's available, all the evidence that's out there. And when you're talking to payers, cost-effective strategies are really important. And we're seeing more and more data from a cost-effective perspective utilizing CMR. So highlighting the differences between the different technologies, but also emphasizing the value you get from a stress CMR versus a stress, an alternative stress protocol. So moving forward to some kind of clinical considerations, Chiara also highlighted this document. This is actually a super critical, comprehensive document as you're getting started with stress CMR. It is going over all of CMR, but there is a section dedicated to stress protocols that will address in detail patient preparation, going through all those really key items to consider. It discusses the pharmacologic stress agents, has tables for contraindications, has potential adverse effects to expect, and also details the necessary stress and safety equipment necessary. So 20-minute talk is kind of outside the spectrum of being able to kind of communicate all of this. It's all in this document. It's excellent. You please use this as your guide. Perhaps the biggest choice to make from a clinical decision-making perspective is your choice of vasodilator. The good news here is that regadenoson and adenosine, which are probably the most commonly used vasodilators in the United States, have been demonstrated in this graphic to the right in a study done well at the NIH that shows even though regadenoson does have more selectivity for the coronary circulation, when you look at the stress CMR perfusion sequences and visually and more quantitatively assess these, you're actually seeing equivalence. Dipyridamole did not show equivalence. It showed some inferiority. It also is less tolerated, but it is cheaper. And I've been part of systems that were at least asking the question, can we do dipyridamole? But I think you can't go wrong with either regadenoson or adenosine. I think from a clinical perspective, mechanistically, there is an advantage to having adenosine, and that basically relates to what we're seeing here with the half-life. So as you know, adenosine is a rapid on, rapid off agent, so the half-life is incredibly short. And as Chiara highlighted, we do our rest perfusion protocols with first pass, basically to exclude that dark rim artifact from susceptibility, Gibbs ringing, and so forth. So if you're doing your rest perfusion and you have used adenosine, you know it's outside the system. So you know that there's no potential ischemic reason for that kind of endocardial abnormality. On the other hand, with regadenoson and a longer half-life, you require a reversal agent, aminophylline, to be administered to try and knock that down. And how much gets knocked down, there's some theoretical data out there, but probably enough for us to be able to highlight that difference. And as Kiara highlighted, rest perfusion sequences kind of depend on the experience of the CMR reader. I think a lot of us have seen so much of this that we probably don't even need the rest perfusion sequence. But if you are starting a stress CMR program and gaining that experience, I would clearly recommend the rest perfusion sequence to understand those differences. But that is why we would need to use aminophylline as a reversal for regadenoson. There are some practical considerations too. So this chart just shows some kind of advantages and disadvantages of the two different vasodilators. So even though adenosine may be more clean mechanistically because it's out of the body by the time you do your rest perfusion imaging, regadenoson is much cleaner from a practical perspective. So you can use just a single IV. So it's a very simple administration. With adenosine, it requires 2 IVs because there's a continuous infusion during the gadolinium and contrast administration. And our patients are older and have various comorbidities. So sometimes getting 2 IVs is a challenge. And so we can't do the exam, or it's caused a lot of patient discomfort. So I have most of my experience is based in adenosine. That's kind of where my heart is. I'm old school that way. But I have transitioned to regadenoson in my current practice, and it has eased the use for sure. It also changes that ancillary role in terms of how nursing and how physician or APP supervision is needed in terms of a time component. So when you're trying to adjust your schedule and FTEs and cost and all those different types of things, it's much easier to administer the agent, wait for the administration of aminophylline, observe the patient, and go about your day. There are cost considerations though, depending on what your health system can secure for cost of regadenoson. It's much more expensive than adenosine. Adenosine does have some hidden costs that may not be incredibly apparent. So if you do utilize a MRI compatible infusion pump, obviously that's a cost. The pharmacy and the nursing time to prepare and administer that is an added cost. And then just the second IV, all the tubing, all those things are things to consider when you look at that equation as to how it fits best in your center. In addition to that cost, you do need aminophylline too. So there's an additional expense, and there's been a shortage of aminophylline. So there could be some potential implications there. So just some things to consider when you're considering a choice of vasodilator for your program. And then the other key distinction from just your standard CMR program, so kind of the focus of where I'm coming about here is I'm assuming most of our attendees are already doing MRI and now looking at adding stress. So the ancillary needs for nursing, for physician or proxy supervision are important to consider. Where they're coming from, as we highlighted, will this be cardiology-based, radiology-based? ECG should be done before your exam, unless there's one available, depending on how you guys are structured and how close it is to the examination. But having the nurse there to administer those things, to shepherd the patient through the process, as it is a little more intense, I would say, than your standard just viability examination. Having the preparation for those things that could go wrong during stress testing, to have a crash cart, an ACLS trained person to administer the pharmacologic agent, give reversal if a regadenoson is used. So there is that engagement to consider, as well as the supervision from a physician and APP level. So again, to discuss this comprehensively is a challenge in 20 minutes. I wanted to touch on some very key aspects to consider as you're kind of building your program. SCMR does support a practice advisory group that is available to answer questions regarding any CMR question. And I would say that if there are questions that don't get answered during our Q&A session today, or if you're watching this offline with the webinar, please feel free to watch out. I've sent a screenshot here that has the resource tab with the practice advisory group, which then opens to this page. And if you're signed in to scmr.org, it will pre-populate all those fields for you that are already kind of in your demographics, and you can ask the simple question. We are available. We want to do this. We want to see CMR be successful and truly impact care for our patients that we've seen in different parts of the world. This is possible. We're seeing this groundswell happen, and we want to be part of that process. So we're super excited, and please feel free to reach out to us. So in conclusion, there are more kind of complex variables to consider in the United States, which is why we are kind of behind. I think we're catching up. I think people are recognizing the importance of information. Costs are becoming a little more contained, and technology is improving. So we're going to be able to do more rapid exams. We're going to get more throughput. So I think that economic impact will actually favor CMR as compared to our other cardiovascular imaging technologies. The key here is really alignment across all your hierarchy of needs, but having that physician champion who's directing the ship is a critical aspect. Again, we've talked about some practical items, some clinical issues to think about as you're building that program. But as we see the data increase, as we see our American side of things incorporate the increasing data and evidence into our guidelines, we're only going to be better poised for success. So I think we're really on the brink of a transformative change in how we utilize these technologies. So I'm super excited for you. And my personal take on this is we're not going to see changes in the United States until we get this out in the community. And this type of engagement, this is what we need to be able to share that message. It's an appropriate message that's grounded in evidence, and one that I think we can tell a story that really will resonate with providers. We'll get more fellows trained in this field, and we'll follow a similar pattern as we've seen across the pond in Europe. So thank you for your attention.
Thank you, Chris. We have two other moderators with us today, Mark Westwood from England and Manish also from England. Do you folks have any comments or any responses to the questions we've gotten?
So, I mean, there was a couple of comments that I would pick up on. I thought the one comment was Chris's comment on the engagement of stakeholders. And I would say absolutely, absolutely get your colleagues on board, go out there, and you've got to work with them, because if they're not going to send you the work and they're not going to send you the patients, and you're not going to set up that entire workflow, you haven't negotiated the scanner time, until you've got that all lined up, it just doesn't go anywhere. And certainly when I set up a long time ago, I spent a lot of time doing that locally in my part of London. And it's a big investment. It takes a lot of time and nothing happens. And then suddenly it all changes overnight. So just listening to that talk, I just thought that was a really key message.
Perhaps I wanted to, I saw a recurrent question was on the use of aminophylline. So in my experience, I've been doing stress perfusion for 15 years and almost every day, and I never had to use aminophylline. And not because I had bronchospasm, nor because I was trying to reverse regadenoson. So I mainly use adenosine in my practice, but I've been working in centers using regadenoson, and I've never been using aminophylline. So I think that's a word of different. Maybe Chris, you want to comment on that? It sounds like maybe you're using it, or maybe you keep it ready in case. But certainly in my practice, yes, regadenoson has a slightly longer half-life, but we're talking minutes. I mean, 2-3 minutes. We're not talking, a long time. And therefore, by the time you've done your Legad, taking the patient off the scanner, etc., I think it's been reversed by itself. And adenosine half-life is 10 seconds. So as soon as you stop it, the symptoms go away, and which is a huge benefit of using it.
I think it's a comfort thing. Making the transition from adenosine to regadenoson to me was actually a fairly significant change. And for me to be confident on the rest perfusion sequences that there was no kind of continued vasodilatation that could be ischemic causing that dark rim is where I've started. It's in our guidance documents in the guidelines reference that I mentioned there to use aminophylline. It's at the discretion. As I mentioned, a lot of more experienced people can be very comfortable with reading through some of those things too. So for me, it was just kind of putting some training wheels on for a while as I get used to regadenoson, and it may very well change my practice over time, and I may not even worry about it at some point. But right now, it's part of our standards. So there's some flexibility there. There's a rationale to utilize it. If there's a comfort not to, I think that's appropriate too. But it is an added cost, and it's an added administration and potential effects and so forth. And so if we could get by without using it, it would be ideal. Absolutely.
I guess where I started in the UK, I never thought along the lines that you said, I mean, which makes complete sense. And so I just, we never given it. And actually the pictures are clear, the RES perfusion are clear, crystalline. So it works in my case.
Great.
So can I ask a question that sums up a lot of the questions, which is basically, how fast can you really go? Do we still need to do RES perfusion? Practically, once you get to a high volume kind of center, or once you get everything really slick, in your experience, how quickly can you get your patients in and out, which has relevance to billing, paying, hospital departments, income at the end of the day. What's your experience?
Kiara, would you like me to start?
Okay, yeah, please.
Okay. So my experience is, it's all based on the protocol. And I think the shorter the protocol, the more throughput you'll have. We've had the ability in my current role as we're building. So we've gone from less than 50 studies a year to over 500 studies a year. So we're not quite at that critical mass. And I'm kind of old school, so I'm still doing some older protocols, trying to do some research sequences and other things. But a 30-minute exam is possible, and it's only going to be more possible as these technologies improve. So we're looking at a couple upgrades that can probably drop it to less than 30 minutes. And again, shortening the protocols, RES perfusions for an experienced reader, unnecessary. How much do you do with mapping? Are you just answering the question for stress perfusion and doing some viability work? I think those are all flexibilities, but I think the reality of a 30-minute protocol, which 5 years ago, I'm not sure if I would have said exists today. And I think will transform, at least in the United States, it'll transform everywhere. But I think economically, as you hit on, will be super critical to engage payers, hospitals, health systems in that whole process.
And just a quick follow-up for those who are really beginning to start, would you suggest bunching the perfusion scans together? Would you make it a perfusion only list, or that might be difficult if you're starting out? Are there downsides to having it mixed up with all other indications?
So from my experience, I've been able to spend a day in the CMR control room. So for me, it just makes sense to bunch them up because I'm there. I'm overseeing the program. I'm training the techs. We're working on enhancing parameters. And we're going through things, and the comfort levels there. But the demand has increased. So I didn't mention this earlier, but of those 1,200 scans in Alaska that I was doing, half of those were stress CMR. And we're seeing that same dialogue happen here, where people understand. It's the classic one-stop shopping, right? You get an echo, you get a nuke, and you get a cardiac PET in a single exam. And it can be done in 30 minutes with high quality and with great data. So I think for me, it makes sense. I think it just is kind of part of your local practice. Because we have to now deal with the volume of referrals we're getting, we have to expand to other days. And that's why I'm training APPs to be comfortable and making sure that patients are safe.
Excellent. I hope you've enjoyed this webinar, and I think there is a lot to learn, I guess, but it's actually a lot easier than what hopefully you thought it was before this webinar. Is there any more comments from our moderators?
Only that I'll see if anyone can beat our record of 16 minutes for an entire study. That's our record at Arts.
It's impressive.
Yeah, but it's possible. I mean, adenosine is 4 minutes. You do your localizers, 4 minutes of stress. You do your single shots like that. It's like, you know, a minute, 2 to exaggerate. And then you do your CNAs if you have to, but maybe you will know already your ejection fraction from your echo. You don't need to. And so that's it. And it is a lot easier than, you know, what you might think. So I really encourage you to start, and SCMR is behind you, and we're really looking forward to guiding you even on a one-to-one basis. You know, reach us, the clinical advisory group that Chris has mentioned that he's chairing, but all of us at SCMR, you know, Mark and Manish, I'm sure they'll be delighted also to help and advise. They have extensive experience, and we have lots of educational content in the website already and more to come. You want to close, Scott?
Yeah, well, thank you very much to all the speakers and to SCMR for hosting not only this session, but this entire series. And I'm sure I and many other people listening today and maybe watch it online later will get a lot of inspiration and ideas from y'all. So thank you very much.
Thank you. And don't miss next Monday. It's a case reading with the experts, same time. Same organization, still from SCMR to you all. See you next Monday.
Great, thank you.
Thanks,
Thank
Chiara. With that, we must conclude today's webinar. You will soon receive an email from the SCMR with links to the evaluation survey for this webinar. To register for any of our upcoming webinars or meetings, or to view recordings of previous webinars, please visit www.scmr.org. Thank you for your participation in today's webinar. We hope to see you here again soon. This concludes today's program. You may now disconnect.